Hello and welcome to today's webinar, Introducing the Blueprint for Complex Care, Opportunities to Advance the Fields. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, phone lines are being muted during today's event. There will be a moderated question and answer session during today's presentation. You may submit a question online anytime by clicking the Q&A icon located at the bottom of your screen. Instructions are shown on the screen at this time. Today's event will be recorded and shared publicly. At the end of the webinar, we ask that you please complete a brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope that you'll take a moment to do this. I will now turn the webinar over to Mark Homowicki from the National Center for Complex Health and Social Needs.
Thank you, Travis. I'm pleased to welcome you all to our webinar on the Blueprint for Complex Care. We are thrilled with the interest in this topic. More than 1,600 people have registered for today's webinar. Today you'll be hearing perspectives on the Blueprint from a number of people and organizations involved in the project. The speakers are listed here in order of appearance. At the outset, I'd like to acknowledge and thank our funders, the Commonwealth Fund, Robert Wood Johnson Foundation, and SCAN Foundation for their generous support. They are part of a Six Foundation collaborative, which is dedicated to promoting the adoption of evidence-based models of care for those with complex health and social needs. The existence of this funding collaborative is a real strength of our field. Susan Mendy is here with us to speak on behalf of the collaborative. Susan is Senior Program Officer from the Robert Wood Johnson Foundation and has been a longtime champion of the development of the field of complex care. Susan?
Hi, everybody, and good morning or afternoon, depending on where you are, and thank you so much for joining us today. I'm really thrilled to be able to be on this webinar with you today because we at the Robert Wood Johnson Foundation are very proud to be a founding sponsor of the National Center for Complex Health and Social Needs, and as Mark has said, also a funder of the Blueprint, along with our other funder colleagues. The foundation has also supported many projects led by some of the key groups authoring the Blueprint, Center for Healthcare Strategies and Institute for Healthcare Improvement, as well as the Camden Coalition for Healthcare Providers over the years. So we know that we have an all-star team assembled to lead the Blueprint work. The foundation was an early supporter of what we now call complex care, and it's been a privilege to support the development of the field and with the work of all of you on the phone to really watch it grow. This Blueprint really comes at the right time. We're at the point where complex care has grown from a radical new idea into a movement and now really maturing into a field of its own. We all know that the transition towards paying for value over volume will really benefit the complex care field. But we also know that social services and even behavioral health are still undervalued in many traditional healthcare settings. So as this field of complex care progresses, we need to expand the evidence base for complex care, and we need to focus on developing a strong business case for why it needs to be covered in insurance networks and payment models. In traditional healthcare settings like hospitals, we know the demonstrated cost savings coupled with value-based payment models is what moves them to action in many times. So ultimately, we need complex care to be seamlessly incorporated across the healthcare system as a rule rather than the exception, so that all patients with complex needs across the country receive care designed around their individual priorities and the range of their needs. The Blueprint is a critical step towards achieving better care for the most vulnerable patients and potentially even dramatically lower healthcare costs. As we knew from the start in working in complex care, this will take time, but now we know the path forward. You are all key points along that path, so we're delighted that so many people have joined this discussion today. Thank you.
Thank you, Susan. Today's program will continue with some additional background on the Blueprint, which I'll give, followed by a review of the assessment findings by Rachel Davis from CHCS, a discussion of the Blueprint's recommendations by Kedar Mate from IHI, And then we'll hear reactions from two of our complex care champions, Chokey from New York City Health and Hospitals and Leah Thompson from Health Leads. Of course, we'll save time at the end for some questions and conversation. What is the blueprint? The blueprint seeks to provide a strategic direction for the emerging field of complex care. When we launched this project over a year and a half ago, the National Center was brand new. Our charge was to help catalyze the development of a new field of practice and create a professional home for those in the field. We saw many different organizations contributing to the field, but often we were all doing so in an uncoordinated fashion. We lacked defined terms, frameworks, and clear goals for the field. At the same time, we saw tremendous passion and energy from a small but growing community. And there were some exciting developments that really held promise to accelerate the field. Things like the creation of the Six Foundation Collaborative, the launch of the Playbook, and the National Academy of Medicine report on effective care for high needs patients. The blueprint really sets out to organize this growing community and build on the work that's already been done to figure out a path forward to strengthen the field. We chose a multi-organizational leadership structure because there were so many organizations developing the field, and we know that complex care itself requires great collaboration. We've been privileged to work with our partners at CHCS and IHI, both of whom have been leaders in their own right in the development of complex care. The goals of the blueprint are to provide an assessment of the current state of the field, and including documenting areas of consensus and providing greater clarity about terms, principles, and goals. We also wanted to learn from parallel fields that were more mature, like hospital medicine and palliative care, about how they developed and spread their practices. Finally, the blueprint sought to develop specific concrete recommendations to advance the field over the next 3 to 5 years. The first question that we set out to define was, what do we mean by complex care? As we mentioned, there's a lack of definition around terms when we started this project that people sought to answer. This slide represents a consensus definition of complex care contained in the blueprint. There are several key components to the definition. One is that the population is characterized by extreme healthcare utilization and cost. The second is that root cause for many people goes beyond their medical condition to include some combination of medical, behavioral health, and social needs. And finally, the lack of coordination and silos that exist between healthcare and social care often contributes to the inefficient use of healthcare resources. On the right is a visual of the complex care ecosystem. As we know, complex care not only seeks to coordinate the individual care of individual people through discrete programs, it also seeks to create systemic change and local ecosystems that break down the silos and facilitate connections between services that have previously been segmented. Finally, we note that complex care is a bridging field. It doesn't seek to replace or compete with other fields like mental health, addiction medicine, palliative care, and others, but instead it seeks to borrow and bridge the knowledge and practices of different fields in service of those with the most complex needs. As part of the blueprint, we identified 5 core principles of complex care. They are person-centered, equitable, team-based, cross-sector, and data-driven. By person-centered, we mean that programs must be designed around individual needs and preferences, that they must address the whole person's needs and not just the physical health or social needs. But given the high rate of childhood and adult trauma, it's essential that services are delivered in a trauma-informed way. By equitable, we mean that complex care recognizes the systemic inequalities that exist in our society, like poverty and structural racism, and that the field also values the wisdom and expertise of those with lived experience. By team-based, we mean that because the needs are so heterogeneous and span various professions, it's important that care teams be multidisciplinary, and that the teams meaningfully include both the patient and their family and loved ones. By cross-sector, as the ecosystem graphic shows, the needs must the needs span traditional boundaries, and therefore we need structures that allow for those sectors to come together and collaborate and better deliver services to people with complex needs. And finally, data-driven means not only that we're using cross-sector data to understand the problem, but also to identify individuals with those needs and to evaluate programs so that we are evidence-based. Next slide, please. The project of the blueprint was started in the fall of 2017 at our National Center Conference in Los Angeles. There, we called on conference participants to provide input through polls and interactive activities. The entire process from the beginning was designed to be extremely inclusive of the broad and diverse community of complex care. The phase in the winter was an environmental scan. We looked at the published and gray literature on complex care. We spoke to a diverse array of experts doing detailed interviews, and also talking to folks that had been instrumental in developing other parallel fields. In the spring, we brought together at an expert convening another group of folks to respond to our findings and to weigh in on recommendations. Finally, in the fall, there was a multi-step drafting process with a lot of external feedback. We also had intensive stakeholder surveys. We had more than 400 people that weighed in through a survey process to really help ensure that the findings that we were gathering through this process were consistent with the feeling of people at all levels within the field. And finally, now we have published the blueprint in December, and we're in the dissemination process where we are sharing it with others and mobilizing partners to make sure that the recommendations become reality. Next slide. On the next slide, you can see just by the numbers, the various people who were involved in the development of this blueprint, from the folks at the conference to the various literature that was consulted, to the interviewees and the survey respondents and other experts from other fields. So this blueprint was really in every way intended to reflect the views of many people in our growing community. So I'm now going to turn it over to Rachel Davis, Associate Director for Program Innovation at CHCS, to talk about the assessment that she helped lead as part of the research phase.
Great, thank you so much, Mark, and hello, everybody. So as we started thinking about this project and really trying to understand what it takes to build a field, one of the things that we came across was the strong field framework that was developed by the Bridgespan group. It's a framework for assessing the strengths and needs of a field, and it's really explicitly designed to help fields become more robust and to help coalesce stakeholders around a set of common goals and priorities. We felt like this was a really useful way to break down where the field of complex care currently is and where it needs to go. And so we were really excited to adopt it to help us understand where the field of complex care is and where there are opportunities to strengthen it. So you can see in the next slide here that there are 5 components to the strong field framework, and the Bridgespan group really has put forward the idea that these components are essential to supporting a robust, cohesive, and sustainable field. The components are shared identity, standards of practice, knowledge base, leadership and grassroots support, and funding and supporting policy. And within each of those, we assess the strengths and weaknesses of the complex care field. We did this through the interviews and surveys and expert convenings that Mark previously mentioned, and felt like we came out of this with a really interesting and useful sense of again, sort of the strengths and the weaknesses of the field. So within this first domain of shared identity, a number of strengths emerged, or folks spoke to a number of strengths, including that there really seemed to be strong agreement on the set of problems that needs to be addressed by complex care. The field of healthcare in general needs to be more person-centered. Social determinants of health need to be better addressed. Care and information are too siloed. Reimbursement systems don't adequately support complex care approaches. As Mark alluded to, there were also a set of principles and goals that folks really across the board seem to identify as core to the field of complex care. And there was a sense that the fact that this field is a bridging field, it's not a separate line, it's not seeking to replace or compete with disciplines, but rather connecting multiple disciplines. There was a sense that that was actually a true strength of the field. In terms of weaknesses, though, there were a couple of points that folks spoke to. One was around a lack of a shared language, a sense that right now the field has been really defined by this idea of saving dollars or reducing utilization, and that we need to be more expansive and articulate about what this work does. Relatedly, there was a sense that we haven't done a great job of articulating who the target population is and why this work matters. And so that was an area that folks pointed to as a place that needed improvement. On the standards of practice domain, some of the strengths that were pointed out by folks that we spoke to were around the fact that there are increasingly more models that are being proven as effective, and the elements of those models are spreading. And we're doing a better job of articulating what some of the features are of those promising models, including things like teamwork, coordination, responsiveness, medication management, sensitivity to trauma. People really felt like we did have more work to do in this domain, however, and I think that there was a sense that the limitations around being able to share data across behavioral health systems, social service systems, and healthcare systems really impeded the ability to coalesce some standards of practice. And there's also a recognition that there's a shortage of providers in this space, both because there are not enough primary care providers in general in this country, and also because we haven't necessarily adapted our training systems or or the way we provide resources to providers to really reinforce some of the core concepts that are necessary for complex care, and that really emphasize relationship building. The next domain of knowledge base, there again were multiple strengths that were pointed out by the folks that we spoke to. There was a real excitement around the growing evidence base that's demonstrating why complex care is important, why thinking about integrating health and social services and social determinants of health is an important way to approach complex care. There was also a sense that we are doing a better job of understanding how to identify subpopulations within complex care and tailor interventions and programs specifically for these subpopulations, recognizing that complex populations aren't monoliths. There's a lot of diversity within that group. And there was also an appreciation for a community of researchers that are emerging and that are helping strengthen the field with their work. There was a sense that their current metrics, however, that we use are too focused on cost and utilization, and that we need to do a better job of developing metrics that truly reflect the type of work and the impact of work that we have with complex populations. So measures that can help assess complex care's impact on the well-being of individuals, on their overall health, potentially on the impact that the work can have on other sectors. And there was a really interesting dialogue that emerged around how we should evaluate these programs. Some of the folks that we talked to really were excited about doing rigorous evaluations, so implementing approaches like randomized control trials. Others felt like those approaches were too labor intensive, too resource intensive, too time intensive, and really advocated for quicker innovation cycles that could allow for rapid cycle testing and refining. So there's, again, a lot of debate in that particular point in that space, and an opportunity to coalesce there to help strengthen the field's approach in this space. On the leadership and grassroots support front, it is really clear that complex care is a high priority and continues to be a high priority for a lot of really important stakeholders. We are seeing this at the federal level, at the state level. We're seeing it from philanthropies like Susan and the Robert Wood Johnson Foundation. We're even seeing large corporations such as Google get invested in this space. So there's clearly support and leadership buy-in, and that was felt across the board, and folks really felt like that buy-in from key segments of the field was increasing. In terms of areas for growth, people felt like although the field of complex care has done a good job, and probably a better job than most healthcare spaces, of valuing individuals with lived experience, there was room for improvement there, making sure that we are recruiting and maintaining individuals with lived experience, making sure that we're providing them with the tools and supports that they need, we're effectively giving them an equal voice in the work, and we're adequately integrating them into the work. There also, as I'm sure most of you on the phone know and experience daily, there's barriers to cross-discipline and cross-sector partnerships that need to be addressed as well. So definitely work in this space remains. And lastly, on the funding and supporting policy domain, there was agreement that the emerging shift within the healthcare space writ large towards value-based payment was a positive, that complex care and a lot of its tenants are really not well supported by the fee-for-service structure, and so the shift towards value-based payment was definitely advantageous and a positive development. And as I previously alluded to, there's the sense that public investment continues and has even accelerated actually in complex care. We've seen this in examples such as the CMS at the federal level, CMS's Accountable Health Communities Initiative, states pursuing health home programs, and actually there's even some examples of states using their 1115 Medicaid waivers to specifically advance complex care efforts. So clearly momentum and funding towards focusing on complex care. That being said, people talked about continuing to struggle with financing and how that relates to sustainability. One of the things that can be a challenge in the complex care space is that these programs may need years, many years, to produce savings, and some of those savings may even accrue to other systems. So there's continues to be some misalignment in the reimbursement systems as it relates to complex care. And also social and behavioral health services are often under-resourced, underfunded, and they can be funded differently than healthcare. And so that can fragment the way that complex care is able to bridge those sectors and really cohesively coordinate with them. So I will stop there and turn it over to Kedar to speak to the ways in which we took these learnings and formulated some recommendations.
Yeah, thank you very much, Rachel. It's terrific to be able to follow you and to be able to be on this call with all of you and to have been able to participate in the process of crafting and helping to build the blueprint. So what you'll see if you're following along the slides is a set of recommendations. The final section of the blueprint has a list of 11 ideas, 11 recommendations. First draft, these are our best thoughts based on what we heard from the many hundreds of folks who we interacted with over the year of building and working on the blueprint. It's a wide list of folks that contributed, stakeholders that have been working on complex care for many, many years, individuals with complex needs themselves, folks with lived experience, in addition to scientists, policymakers, and others who helped us to build the blueprint over this entire year. So there were 11 recommendations. We don't have time to go through all of them. We could really highlight any of them because they're all, I think, the three primary agencies that helped to craft the blueprint. We felt strongly about all of them, and so we wanted to offer all of them to you for your consideration and for your thoughts. For today, for this webinar, we're going to just highlight a few. We're going to highlight 5 of them in more detail. But before we dive into those 5 specifically, I wanted to just pull back for a second to show you how we crosswalked our recommendations with the 5 domains of the strong field framework that Rachel just took us through. And specifically, we looked at how to address some of those weaknesses. So in the previous discussion that Rachel led us through, there were, in each of the 5 domains, we noted that the field had some strengths and had some things that we needed to work on with respect to the field of complex care. And so the recommendations are really a direct response to those areas of weakness. These are 11 ideas for how we could improve our work as a field together with all of you on those areas of weakness in the 5 strong field framework domains. And so on this slide, you'll see a kind of crosswalk between each of the 11 recommendations on the left and each of the 5 strong field framework categories on the horizontal axis, and you'll be able to see kind of where each of them touched on the areas of weakness that we found in the strong field framework. So that's the idea here behind this list. So let me take you through 5 key recommendations that we thought we'd highlight so that you could hear a little bit more about what we included in the blueprint. So the first one, if you'll go to the next slide, the first one is about developing the core competencies and practical tools to support their use. So when we started with the question of what will it take to deliver evidence-based and effective care for individuals with complex needs, we thought that one of the areas that we needed to improve upon was the development of a set of core competencies upon which future training programs, both initial training and continuing education, could be developed and refined. We noted that these competencies, these core competencies, ought to be developed by a cross-sector group, including individuals with lived experience on those groups, so that we could develop a set of competencies that were reflective of the need and the practice that we needed to have today. We didn't specify at this time that those competencies need to become formalized into potentially formal certification standards, but we noted that they could evolve in that direction, that we can move from a set of competencies today to a set of potential future standards that can help with the challenge of increasing the total numbers of professional staff to help with the challenge of complex care in the future. The second recommendation is recommendation number 2, and that's about measurement. So the recommendation is about developing quality measures for complex care programs, and this one is about the development of process and outcome measures that would understand the quality and effectiveness of complex care efforts. We recognized very quickly, very early on, that there are a variety of efforts already underway to help understand the quality measurement as it relates to complex care and to help further simplify, standardize, and make it easy for folks to capture those, capture that knowledge and measurement today. There's the work of CMS and NQF, among others, including independent investigator-led efforts that are seeking to understand the quality and the quality measurement landscape. Our hope in the second recommendation is that we would collectively understand those existing measures, that we would seek to reduce the measurement complexity and burden associated with complex care, that we would match measures to goals of complex care programs, and very importantly, that we would move beyond cost and utilization measures alone to measures of impact, health, and well-being of patients and populations. I'm going to skip a few and go to number 9 for the next recommendation that we're going to highlight. This one's about payment. We know we won't be able to sustain this field of complex care without creating and then leveraging new payment mechanisms to ensure durable financing for complex care programs. We recognize, as Rachel pointed out in the previous talk, that there is more alignment today with complex care with value-based arrangements, and that there's much more that can be done to create durable funding in perpetuity for complex care efforts. This recommendation encompassed areas about establishing the business case, documenting promising uses of alternative payment models that are in use today, collaborating with state and federal payers to test new payment models, and then some more specific and focused recommendations around the development of resources, coaching, training, materials, templates that would help community-based organizations contract with managed care and with accountable care organizations, that would work with those same or other organizations to leverage new supplemental benefits opportunities, that would work with MA plans to expand coverage for social and non-medical needs, and that would offer specific guidance around the use of billing codes for complex care, for care planning, for transitions, care coordination, home health, et cetera. So a lot of very specific recommendations and ideas captured here under this idea of leveraging alternative payment models, number 9. Let's go to number 10 now. This is in order to execute on any of the recommendations in the blueprint, we recognize the need for some kind of a formal structure to house all of this activity. The literature and prior experience supports the idea that while many actors are obviously necessary to make any of this happen, that we need some mechanism to bring it all together. Many of you will be familiar with John Cania and Mark Kramer's collective impact work. This is akin to the backbone support organization that they described in their now famous article on collective impact. This idea that there's some kind of mechanism that brings us all together, that helps us to coordinate the activity and helps us to develop the work of the field of complex care. The field coordinating committee, as we called it, would be a multi-organizational structure. It wouldn't be any single organization that would produce these activities, but it would be a group of organizations working together, making common cause around improving care for individuals with complex needs. There'd be a defined set of committees that would help to execute on the work. And a commitment that we offer in the blueprint is that the work of the field coordinating group and all of its committees would be fully transparent and accessible, and will always seek to involve as many as are interested in the activities of the field. And the last recommendation that I'll highlight here is that none of this, this will be if you can go to the next slide, none of this would be done without the leadership of those individuals with lived experience. All of this work would be intentionally led and driven by the beneficiaries of the field. There are a lot of organizations we recognized in the blueprint that are already working on this, that are working to ensure that this is happening, and the blueprint would work to build on that effort. People with lived experience would be in all formal committees, all formal decision-making and oversight groups, and would drive the research and practice agendas. And by doing so, I think would really distinguish this field from many that have come before it. This is a recognition, while we offer this, this recommendation, we do recognize that the complex care community itself is diverse and that there are many perspectives that will need to be represented. And finally, we also recognize that the development of this field in particular is a socio-technical phenomenon. This is as much about stories and relationships between individuals as it is about the structure, data, and the money flow. So on the next slide, we're going to talk about some next steps. So those are some of the recommendations. Again, there's 11 of them. We've picked a few to go through just now, but we're happy to reflect in the Q&A on any of the others if they strike you or you want to hear more about them. But what next? How do we move from an ambitious document covering a lot of territory to equivalently ambitious action? What we offer here are some first next steps to catalyze collective action. We know first steps like those of any young child will be, we'll stumble and we'll fall and we'll pick ourselves up again and try again. But here's our first go at what we think will be necessary to move the field forward and to catalyze collective action. The first is to pick these recommendations and sequence them. It's not about, we want to get to all 11 of these ideas, and I'm sure as you look and interact with this, you'll offer us many more. But we need to prioritize some of them to get started. So we're going to be working on doing that. We want to establish mechanisms for working together, for coordinated action, and for moving the field forward. And then finally, we want to engage all of you in that process and for us to move this field forward. So on the next slide, how can you contribute? How can we get going on this? Well, the first way of doing this is to provide us with some feedback on the blueprint itself. There's a link in the slides and that we can perhaps chat in to help us further understand the blueprint, what you think could be improved about it. Provide us with your feedback. We're open to all of it, and we look forward to hearing from you. The second is to participate in upcoming blueprint activities. We'll be conducting a series of meetings, office hours. We'll be building a network of interested organizations, et cetera, that would be interested in some of this work. We'll share that information with all of you, and we'd hope that you would join us for some of those activities in the future. And the last is to sign up to become a complex care champion. Becoming a champion is a really exciting thing. Already we found that there are 47 organizations who have signed up for becoming a blueprint or a complex care champion. And by doing so, they've endorsed many of the findings in the blueprint and have suggested, have supported the spirit and the ideas of the blueprint itself. On the next slide, you'll see those 47 organizations that have signed up to become part of this. These are folks that lead the field already in policy, delivery, implementation, working with individuals with complex needs themselves. And they are helping us now to shape the blueprint going forward. And they will be among the first to know and the first to be asked to be part of the blueprint's subsequent activities, including the work of the field coordinating committee and the future infrastructure that we hope to set up. So we hope that you will consider joining the complex care movement and by becoming a champion in that effort. So you've heard from me about some of the recommendations, and you've heard about the idea of becoming a champion. So what we're going to do now is we're going to hear from two of these champions that are part of this list. We're going to first hear from Dave Chokey, who's the Chief Population Health Officer from New York City Health and Hospitals. And then we'll hear from Leah Thompson, the Vice President of Programs and Learning from Health Leads. So I'm going to turn it over to you now, Dave, to get us going and tell us your perspective on complex care. Go ahead, Dave.
Great. Thank you so much, Kedar. And let me start just by thanking the organizers who have been so deliberate about translating the concepts that Kedar walked to into collective action. And it's just an honor to be a part of this movement with almost 900 people on this webinar already. And I'll also say, we signed up as a complex care champion in the sense of our commitment to addressing the problem, not necessarily in the sense of having even a whole lot figured out with respect to what our complex care approach should look like. But you can see from the slide here that we have very strong motivation to actually figure it out. We are, for folks who don't know about our system, we're the public healthcare system for New York City. We take care of about 1.2 million patients across the 5 boroughs of New York City, about 300,000 of whom are uninsured. And for our full population, we take care of the poor and the working class of the city, people who reflect the ethnic and cultural diversity of New York. We have a significant footprint with respect to our integrated system. You can see some of the numbers here, 11 acute care facilities, as well as over 70 community-based clinics. And we have, a particular kind of vantage point on some of the vulnerable people in New York, both in terms of the behavioral health services that we provide, the fact that we take care of people before, during, and after incarceration because of correctional health services and the relationship between correctional health and the rest of our system. And then toward the bottom, you can see, some of the things that I'm sure many of you are also grappling with respect to what it means to serve the patients whom we do. There are tens of thousands of patients who are without a home, thousands of patients whom we would consider high need based on whatever definition you invoke with respect to physical health, behavioral health, and social needs, as well as functional limitations. And then, as again, many of you are familiar with, a significant number of patients who spend more days in the hospital than out of it in the past year, which I think is a chance for us to step back and just realize, the human side of the problem that we're trying to take on. So this kind of tells you a little bit about my vantage point from health and hospitals. And I'll say when we talk about complex care here, we often, particularly in our conversations with frontline clinicians, call upon the concept of triage. The fact that our hospitals are organized based on the principle of triage. We have intensive care units and step-down units and hospital wards. And the first thing that happens when you walk into our emergency department is you enter into a process of triage. But we don't necessarily do that same type of triage at the system level for the patients whom we're responsible for. And so we found that that is a particularly resonant way to have people visualize what it means that when we talk about complex care and the patients that we're trying to serve. But I think you can also see from the numbers that are shown here that it can be overwhelming. Many people don't know where to begin, particularly at the scale of our system, as well as some of the resource limitations that we struggle with. It's easy to feel a sense of paralysis about where to begin. And I think the blueprint and the community around the blueprint has really given us a foothold, both in terms of substantively how we should start to think about our complex care programs, but equally to know that there is this field of like-minded pioneers whom we can exchange ideas with and learn from, and sort of muddle through, some of the real-world problems associated with delivering complex care together. So I'll just give you two, quick examples of that in terms of how the blueprint has been important for our work already. And the first is really the idea that, a couple of years ago at Health and Hospitals, we had made some progress in identifying who our high-need patients were through a process of risk stratification, as I'm sure many of you have undergone as well. But it was really through interacting with the community that the blueprint has put together that we were able to take stratification to the next level and think about segmentation, basically making subgroups of high-need patients more clinically salient, and then ultimately targeting, so figuring out how to strike the balance between matching up very resource-intensive interventions with the patients who are most in need and potentially who have modifiable risk as well. And so that framework, that sort of intellectual ballast really came out of being involved in this community. And the last thing that I'll highlight is one of the other recommendations that Kedar went through, number 7, which is about strengthening local cross-sector partnerships, which particularly for a healthcare system as we are, I think is very important for us to keep in mind. So when we talk about our patients who are homeless, there should be the reflex to partner with community-based organizations and other institutions who have been taking on this entrenched problem for longer than we have, and in many cases are more trusted by the patients that we're trying to serve. And so that for us has been a particularly important recommendation to try to operationalize. So I'll leave it there and pass it back to you, Kedar, but I look forward to the Q&A as well.
Thanks, Dave. We're going to go straight to Leah as we're in the interest of time. So go ahead and orient us to what is happening now at Health Leads.
Thanks, Kedar. Hi, everyone. So pleased to be here and have the opportunity to speak to the Blueprint. For those of you who are not familiar with Health Leads, we are a national nonprofit that seeks to improve the health of communities by making it easier for people to access the resources they need to be healthy. So in industry terms, this really means we're focused on addressing the social determinants of health in order to improve the health of populations. And this is what we've been focused on for more than 20 years. So my reactions when I read the Blueprint were first, lots of alignment. I don't know that there's really anything in here we don't agree with, which is wonderful. But also, and I think more importantly, this is where I see one of the biggest opportunities that folks have already spoken to a bit, is one of relief, because I think that the Blueprint does have an opportunity to really knit stakeholders together better in this field so that the people we seek to serve are better served sooner. And so, you know, one of the things I did was just reflect a little bit on the field and how it's shifted over the past 3 or 4 years. And if you think about social determinants of health alone, we went from a place with relatively little information on the how, and really in a lot of cases still making the case for why, to where we are today, which is really different, with lots of stakeholders innovating and sharing learnings on how to address social health. Lots of toolkits, training, technical assistance providers. And so while this rapid increase of stakeholders contributing value to the field is encouraging, I do think we need to be better connected to what each other is learning and build off of each other's efforts better. Because if we're better knit together, care can be too. And there's our chief clinical officer here at Health Leads once said something that's really stuck with me. Which is patients come integrated, their care needs to be. And so by its nature, the Blueprint can really support this by inherently spanning clinical, behavioral, and social domains and making sure they're truly integrated. So just a few, I wanted to speak to a few of the recommendations that really stood out to me based on where Health Leads is right now. So we're really focused on a few key things. One is the workforce to address essential resource needs, identifying this workforce and supporting them and sustaining them, figure out how this workforce gets access to the data they need to really improve health, and deploying this staff against the goals that are most important to patients and community members, and really understanding what those goals are. So with those 3 things in mind, you know, the first recommendation I would pull out is the one around competencies, and I really kind of read this as workforce, a lot of it being around workforce competencies. And there was a specific recommendation within there, which involves convening the staff doing this work with the experts to determine the needs and competencies, you know, because you know, we believe that community health workers, for example, know what they need to be successful. And so recently, there's a program that we've been running here in Boston with community health worker teams from a number of local health centers. And it began with a really strong focus on screening tools and referral and navigation workflows, data collection around access to essential resources. But the community health workers actually voiced much more of a need for support around the sustainability of their roles. And much of this is related to the trauma that is absorbed in their day-to-day work. And so we focused on integrating more support in terms of things like boundary setting and supplementary case support, and giving people a space to really process what they're experiencing through their work. And also providing more and more clarity of scope around their support for social needs and how to better align everyone in their institutions around this. So the result of really listening to the community health workers has been a curriculum that, you know, staff feels addresses the core of what they need to be successful in providing essential resource support. So really an important blueprint recommendation. A second one that I would call out was also already highlighted was the quality measures, you know, particularly measures that better get at real whole person health and well-being. You know, so, you know, we've had, you know, pretty good process measures for years that we've relied on for really specific aspects of our work here at Health Leads, and we've had some experience connecting these to some of the more common outcome and cost measures, but we really need to go beyond these as the blueprint recommends. So we're actively trying some new measures in the social health space, some validated, some innovation measures, but there's no question that if we had standard measures, we could more rapidly discover the changes that are most meaningful and impactful to the people that we serve. But right now, we're still investing lots of time in learning about the measures that can help us do that. And then lastly, but probably most importantly, the valuing the leadership of people with lived experience. So Health Leads has been investing heavily in what we call patient leadership and the ways in which that can be well executed. And for us, this goes beyond just integrating patient voice to being more and more accountable to patients and community members. And so the results of this have been, you know, the ability to test more patient-centered measures, better workflows, better language as we do this work, and just more common sense. Because asking people to help design and improve the programs that are meant to serve them and setting them up well to do that is just what makes sense and is what is needed to improve impact. So definitely a critical blueprint recommendation. So for these recommendations and again, the overall opportunity for coordination that the blueprint offers, Health Leads supports it and is excited to collaborate with folks in this field. So thank you.
Thank you, Leah and Dave, for your perspectives on the blueprint and your work to develop the field of complex care. We now have time to answer some questions from the audience. As Travis explained at the beginning, please enter your question using the question function at the bottom of your screen. We've already received a few questions. The first one comes from Paula Griswold I think in Massachusetts. And I'm going to send this to Kedar because this is a conversation that we've had a few times in developing the blueprint. But the question is complex care really a separate field as opposed to the definition of key contextual factors that clinicians and healthcare institutions should consider in providing effective patient-centered care to all patients?
Yeah, well, thanks, Paula, for the question. This is Kedar. So I would say my thought on this is that, and much of what we debated as we were developing the blueprint is, you know, whether this is its own field, is it part of every field, is it something that needs to be somewhere in between? And I think what we landed on, and you know, Mark, I think earlier in the presentation showed that image of how complex care is really part of an ecosystem of other practices and other fields, including and multi-sectoral efforts. And this is not just not purely from a clinical perspective, but really a multi-sectoral. It sort of sits at the nexus of a multi-sectoral set of solutions. But my sort of more direct answer to your question is that it's probably a both-and situation. I think there's probably some elements of some core complex care competencies that need to be incorporated into every clinical and ancillary, or not just purely clinical, but all healthcare organizations should have some knowledge or some working knowledge of how to work on complex care. And there is a need in many cases for a fundamentally different system. I don't know that we have the system design that best manages and improves care for individuals with complex needs across a variety of circumstances in which those individuals live and work and play and do everything else that they do. And therefore, I think there is utility or value in specialization, in knowledge, deep knowledge about what it takes to improve care for individuals with complex needs. And so there's something that everyone needs to know that should be worked into everything that we do clinically and that healthcare organizations do. And I think there's room and opportunity for deep knowledge and specialization in certain instances. So I'll leave it at that.
Great, thanks, Kedar. Here's another question. I'll send this one to Rachel. How are prevention or upstream factors incorporated in complex care?
So, I mean, I think they're totally central to complex care. I think that we've seen that so much of what drives complexity is actually on the social determinant side of health things, and I think increasingly our understanding of things like adverse childhood experiences, toxic stress, are really making it clear that we need to focus a lot on upstream work. I think this idea of getting a little better at segmenting our populations can help us get at that and can maybe help us identify populations that are, one of the things we're thinking about at CHCS right now is doing a better job of thinking about folks that are at risk of becoming complex. So I think the concept itself is totally central to complex care, and I think we have a lot of work to do to figure out how to best integrate upstream interventions and the concept of upstream work into the space. But I feel like there's, sort of agreement across the board that, ultimately the goal with this work is to, in some ways, sort of put ourselves out of business here and stop people from becoming complex in the first place. And the way to do that is by thinking about upstream intervention.
Great, thanks, Rachel. I think our last question for the day, I'm going to send this to Dave. If you were to look out 10 years from now, what would you hope would be different in this field compared to today?
What a great question. And, I'll give sort of a simple answer, which is that I hope 10 years from now, certainly the CEOs of all health systems and health plans, but also really any organization that is serving people with complex needs, feel the impetus to turn the spotlight inward to ask, what are we currently doing for our high need patients, for our complex patients, and what more should we be doing? And I think if we undertake the work that is laid out in the blueprint and really strive to create that collective action that we're talking about, that it will go beyond this community that is starting to talk about it until it's business as usual for organizations who are taking care of complex patients.
Great, thanks, Dave. And I just want to thank everyone on today's webinar, all the panelists and participants, as well as all of you listening in and posing your questions. I think there was some great thoughtful questions and robust conversation. If your question wasn't asked, or if you have other questions that you want to contribute to the conversation, please consider joining us for our office hours for complex care. It's the second bullet on this slide. It's in February. It's going to be a more intimate conversation, 30 to 50 people, and it's in a flipped webinar format where most of the time will be spent with questions and comments from participants as opposed to the speakers themselves. So I also want to just remind everyone what Kedar invited you to do earlier today, which is organizations can sign up to become a complex care champion to indicate your organization's commitment to the field and endorsement of the recommendations of the blueprint. We also wanted to, can you go to the next slide, please? Wanted to make sure that if you're interested in learning more about complex care and following the opportunities that will come about over the next months and years to be part of the development of this field, please sign up for our respective newsletters and get these updates. You can see here links for the National Center for Complex Health and Social Needs, Center for Healthcare Strategies, the Better Care Playbook, and this week at IHI. So we will be sending out the slides and the recording from this webinar to everyone who registered. And I want to just, again, thank you all for joining and hope you have a great day. Thanks. Hang on. Yep.